Okay, so can you see this now?
Yep, all good. Thank you.
25-week preterm baby. And the question here is how we go about best nourishing this baby. Well, this is a 25-week gestation preterm, and this baby should still be in the uterus. And when this baby is in the uterus, he or she is getting a continuous supply of glucose. Protein is taken up at around 4 grams per kilogram per day. That fetus is getting lipids at 3 grams per kilogram per day, and also receiving 150 milliliters per kilogram per day of amniotic fluid through the gastrointestinal tract. So the gastrointestinal tract is not just resting in this fetus. The gastrointestinal tract is actually being used. Now, in terms of prenatal enteral nutrition, we do have swallowing in the fetus, like I just mentioned, and this develops at around 18 to 20 weeks gestational age. And there is some evidence that amniotic fluid does contribute to nutrition of the fetus because it contains about 4 grams per liter of protein. This is somewhat less than what you find in human milk. Human milk is around 10 grams per liter, but it does contribute to some of the nutrition of the fetus. In rabbit models, it's estimated that 10 to 14% of fetal nutrition comes from the amniotic fluid. Now, when a baby is born preterm, this preterm baby has a decreased amount of gastric acid production, has increased permeability of the gastrointestinal epithelium, has reduced immunoglobulins and immature mucin barrier. So this is a very vulnerable intestine, very fragile intestine that is prone to insults for various reasons, including these. And if you'd like to perhaps read more about this whole issue, we recently published a paper, review article that I refer you to, and it's titled Gastrointestinal and Feeding Issues for Infants Less Than 25 Weeks of Gestation. But I'll be talking about some of this as we go through this lecture. So in the past, it's been very common that we use all kinds of excuses to withhold enteral feedings in these very fragile preterm babies. Why? Because we're concerned that these babies are not going to be able to tolerate these feedings, or that these babies might get what we see on this slide here, very distended abdomen, and this is what we commonly refer to as necrotizing enterocolitis. And there are all kinds of dogmas around enteral feeding of preterms. And these dogmas state that umbilical catheters should not be, if we're using umbilical catheters, we should not be feeding babies. If we've had low APGAR scores, we should not be feeding these babies. If there's apnea, bradycardia, mechanical ventilation, CPAP, they're on vasoactive drugs. If they're on indomethacin, we should not be feeding these babies. These are all dogmas in neonatology, but none of these are evidence-based. And I think that's very important to remember. These have just seemed to make sense to people, but the evidence behind these practices is really not there. So where do we go with this? Well, here is on the bottom of this slide, Richard Ehrenkrantz. He is a neonatologist at Yale University, and in the late 1990s, he looked at the weight gain of a reference fetus that's in utero, and he looked at the 50th percentile of weight gain and the 10th percentile of weight gain. And then he looked at babies who were born and taken care of in the neonatal intensive care unit. Here's 24, 25 week, 26, 27, 26, 28 to 29 weeks gestation. And we can see that the average weight of these babies lags behind, well behind that of a reference fetus. So we are actually causing extrauterine growth restriction in these babies. They are not growing anywhere near the same way that they would be growing in the uterus. And this is a potential cause for alarm. Why? Well, Here's another slide that I think should be very important to our understanding of the body composition of these extremely low birth weight babies. So here we have 24-week, 26, 26, 28, 40-week gestation babies. And here we see some of their body composition. This 24-week gestation preterm has 1% body fat, 0.1% body fat. That provides about 19.5 calories. The 26-weeker has a little bit more, 1.5% body fat, which can provide 123 calories. But that energy store is really not enough. It would take a very short period of time to utilize all that energy. And this preterm baby, once this energy is utilized, the fat energy is utilized, this baby will begin to undergo catabolism, breaking down the rest of the lean body mass to produce glucose. So this is highly problematic. We know from numerous studies that if a baby is being fed enterally, exclusively by the intestinal route, usually that baby can grow at 100, if that baby is getting 120 calories per kilogram per day. If that baby is on TPN, that means no enteral feeding, one can attain positive nitrogen balance with 60 calories per kilo per day with about 2.5 grams per kilo per day of protein. But if you want that baby to grow on TPN, you have to give that baby approximately 80 calories per kilogram per day. Now, in most of these very low birth weight micropreemies, we cannot get to full enteral feeding quickly, and we have to use intravenous nutrition as a bridge to full enteral feeding. But we can get to enteral feeding much faster than we thought we could in the past. In the past, it was very common to sometimes keep babies NPO for 1, 2 weeks, and even longer. This is no longer our practice, and this is a practice that we are now undergoing based on evidence, which I'll show you. Now, in terms of the energy requirements of this 25-week preterm baby, I said before, that baby requires about 120 calories per kilo per day. What does that equate to in terms of an adult? Well, here's an adult who is doing the Tour de France, riding his bicycle all day long. With riding that bicycle all day long, that guy needs 7,000 calories per day. And assuming he's 60 kilograms, he is getting 120 calories per kilo per day. But that is as a Tour de France bicycle rider. So this is telling us that this baby is requiring a tremendous amount of energy. This is not just for metabolic processes, but also for growth. The amount of protein on a per kilogram basis is also huge that this baby requires. Preterm infants require 4 to 5 times as much protein per kilogram compared to an adult. So this is telling us that this is required not just for metabolic processes, but also for growth. If you think of how fast a fetus is growing in utero and how fast a preterm baby should be growing in terms of the growth curves, preterm baby should be doubling or tripling its body weight within the first 2 to 3 months after birth. And that is one of the reasons why this baby on a per kilogram basis requires so much energy and so much protein. If the babies do not get this, then this could be problematic. These are graphs showing the MDI, Mental Development Index, Physical Development Index less than 70, cerebral palsy rate, and also neurodevelopmental impairment at different feeding levels in preterm babies. So here we see very low feeding level, here's a high feeding level. And we see that the mental development index is much better for those babies who are getting a higher amount of feeding per day, 21.2 versus 12.0. And neurodevelopmental impairment down here is considerably less in those babies who are being fed higher quantities on a per kilogram basis. Now, I just want to talk a little bit about parenteral nutrition before I get into enteral. And we sometimes are very slow with initiating certain types of parenteral nutrition. For example, it's dogma that we should be providing slow incremental increases of lipid to our micropreemies. So for example, many neonatal intensive care units start with 0.5 on the first day, 1, and then 1.5 on the third day, then 2. They go up very slowly. There is no rationale for that. And numerous studies have shown that we can provide between 2 to 3 grams per kilo per day safely to these babies of intravenous lipid if we provide that over a prolonged period of time, over 20 hours in a slow continuous infusion. We know that essential fatty acid status in early infancy is low. And this is rapidly exacerbated with lipid-free nutrition, and I'll show you a slide on that shortly. And we also know that long-chain polyunsaturated fatty acid derivatives from essential fatty acids are important in brain and retinal development. And so these need to be supplied. And we also need to provide energy in the form of lipid to prevent catabolism and to spare protein. So let's just talk a little bit about the essential fatty acids. And what do we mean by essential fatty acids? These are the fatty acids that cannot be produced by the body. They have to be taken in via dietary sources. And these are linoleic and linolenic acid. And you can see there's an omega-2 fatty acid and an omega-6 fatty acid and omega-3 fatty acid. So the linoleic is an omega-6, linolenic is an omega-3 fatty acid. What does this mean? Well, very simply, we have 18 carbons in both of these long-chain fatty acids, these essential fatty acids. We have a certain number of double bonds, and this is the nomenclature used for our the way that we name these fatty acids. And here is the position of the first double bond from the non-carboxyl, the omega or the N-terminus. This happens to be oleic acid, which is a monounsaturated fatty acid. By monounsaturated, we mean that there is only one double bond. The omega-6 and the omega-3s have their first double bond at the 3 position or the 6 position from the methyl terminus. And that's why they are called omega-3 and omega-6. And these are precursors for very important long-chain fatty acids such as DHA, docosahexaenoic acid, or arachidonic acid. And so the linoleic and linolenic acid get elongated and desaturated to produce these longer chain fatty acids. In the preterm baby, these desaturation elongation mechanisms are lacking, and many babies cannot really perform these because of enzymatic immaturities. So we also, in many of these babies, have to give docosahexaenoic and arachidonic acid. Now, getting back to the amount of lipid that these babies require for growth, before I mentioned that we need 80 calories per kilogram per day if these babies are being only fed by the parenteral route. And here, if we assume that the baby is getting glucose at 8 milligrams per kilo per minute, that provides 39 calories. Amino acids at 3 grams per kilo per day, that provides 12. And if you do the calculation, you still need approximately or close to 3 grams per kilo, or 3 grams per kilo per day of lipid to provide the full 80 calories per kilogram per day. So that has to be supplied if we want to provide for growth in these babies by the parenteral route. Now, here's just a couple important summarizing messages in terms of lipid. The in utero lipid supply is approximately 2.5 to 3 grams per kilo per day. And that's what we should be providing to these babies right after birth. There is no reason why we cannot be doing this right after birth. Essential fatty acid status in early infancy is low and is rapidly exacerbated with lipid-free nutrition. The long-chain polyunsaturated fatty acid derivatives from the essential fatty acids are important in brain and retinal development, and we also have to give these lipids for the prevention of catabolism and protein sparing. So in terms of lipid, what day do you start? How much do you start with? You should be starting at around 3 grams per kilo per day and providing that over approximately 24 hours a day in terms of the lipid support. What about amino acids and proteins? Well, this is a picture of a good friend, Patty Thurine, who she actually passed away quite a few years ago, had early onset Alzheimer's disease, but she had some fantastic contributions to the field of neonatal nutrition. And this just happens to be one of them, where she did some studies looking at protein balance when babies were getting 1 gram per kilo per day of amino acid, shown here, versus 3 grams per kilo per day of amino acid. And these were the nitrogen balance measured by 2 different techniques, using nitrogen balance method with isotopes, and the other just looking at the amount of nitrogen that came out of the urine and the stools compared to the amount of nitrogen that went in. And you can see that the nitrogen balance with 3 grams per kilo per day is much better than with only 1 gram per kilo per day. In fact, you hardly get positive nitrogen balance with 1 gram per kilo per day. So we need to provide at least 3 grams per kilo per day. Is this safe? Well, she found that the BUN levels really do not differ if you give 3 grams per kilo per day versus 1 gram per kilo per day. And another interesting finding was that the high amino acid intake, the 3 grams per kilo per day, versus the low amino acid intake, resulted in the same amount of blood glucose, but the insulin level with the high amino acid intake was considerably higher, almost twice that of the low amino acid intake, suggesting that you had a stimulation of the insulin secretion by these amino acids. So how does that work? If we have delayed TPN, you can get hyperglycemia and hyperkalemia. So the way this works is if you delay TPN, you have low leucine, arginine, and other amino acids. These are known to stimulate insulin, and if they're low, then the insulin level stays low. With a low insulin, you have high glucose, and with high glucose, potassium goes out of the cells. So you end up having hyperkalemia and hyperglycemia in many of these babies who are not getting early amino acid intake. Here we have the same baby, but now 27 weeks gestation, and baby had Apgars of 3 and 5, has UA and UV catheters in place, is on mechanical ventilation, and is getting prophylactic indomethacin to try to prevent intracranial hemorrhage. So the questions we have here: can we feed this baby using the GI tract? What are the consequences of not feeding this baby, and how do we enterally feed this baby? Well, over 60 years ago, Professor Elsie Widdowson in the UK did some studies on the suckled pig, and she found that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. This is what is called the trophic effect of food in the gastrointestinal tract. If you don't put food into the gastrointestinal tract and just provide nutrients intravenously, you have very minimal, if any, trophic effect on gut growth. So this is problematic. Even though you may be nourishing the baby if you're giving TPN, you are not providing a trophic effect on the gastrointestinal tract. There were other studies done in the UK, and this is a study done in the late 1980s by Dr. Alan Lucas and colleagues looking at several gut hormones, enteroglucagon, gastrin, GIP, motilin, and neurotensin. And at birth, they saw these levels. At 6 days, they saw these levels, and these were babies who were not being enterally fed. So that meant that from the time of birth to 6 days, you saw no difference in these hormonal levels. But if they were fed, and even if they had respiratory distress syndrome, you saw a marked increase in these gastrointestinal hormones. So these are very important hormones, several of which cause gut growth and also improve motility of the gastrointestinal tract. So if you don't put food into the gastrointestinal tract, you don't have the secretion of these very important hormones. Gastrointestinal motility also increases over the gestational period. And here what we see an immature motility pattern in babies. The green represents immature motility pattern in babies at 24, 27 weeks gestation, 28, 31, still quite a bit of immature motility pattern. 32 to 35, it begins to improve. 36 to 42, very little of this immature motility pattern. And from the previous slide, we showed that introducing enteral feedings is something that actually will improve this motility pattern. What happens to the liver if you do not provide enteral nutrition? Well, here's a picture of piglets who were being fed by the enteral route versus the parenteral route over here. And you can see after 7 days of being on total parenteral nutrition, no feeding, that's on the right, we see a liver that looks very different than the liver on the left. We see an H&E section, ballooning of hepatocytes. We see fat staining and glycogen staining in the liver of the piglet that was only given TPN. So only 7 days of TPN can actually cause these changes in the liver of these animals. Over the past several decades, we've begun to recognize more and more that we can provide at least small amounts of feeding to preterm babies. And this happens to be a paper that we wrote in 1992 that was titled Gastrointestinal Priming Prior to Full Enteral Nutrition in Very Low Birth Weight Infants. And at that time, at least in the United States, it was very common not to give any enteral feedings to babies, to these preterm babies for a week and sometimes 2 weeks after birth. And we introduced this technique called gastrointestinal priming, where we gave small quantities, less than 20 milliliters per kilogram per day in the first week after birth to these babies, just to provide some food to the gastrointestinal tract. Even that was a very difficult concept for neonatologists to grasp onto in the 1990s, but we've changed considerably since that time. Here's another study that was done at Baylor University looking at what happens to the permeability of the gastrointestinal tract if you don't put food into the gastrointestinal tract of preterm babies. So here's the mean birth weight of the babies in this study, 1 kilogram, and their gestational age was about 28 weeks, and there were two groups. One group was receiving GI priming, that's small amounts of feeding, around 20 milliliters per kilogram per day from day 4 to 14. And the other group was receiving TPN, no enteral feeding. What happened to the permeability of the gastrointestinal tract in these two groups? Well, the blue here represents the TPN only, and you can see that the permeability as measured by the lactulose to mannitol ratio is considerably higher in those babies who are getting TPN only. This means that you have a greater leakiness of the gut in those babies who are not having any food placed into their gastrointestinal tract. There's also another interesting finding that was looked at in animals, and this is a study done at University of Michigan a little bit over around a decade ago, and this was done in mice. And what they did was they gave mice TPN and did not give them any enteral feeding versus feeding them. And you see that the microbial ecology of the gastrointestinal tract differs markedly in those animals, those baby animals who were fed versus not fed. This blue in the unfed animals represents a phylum of bacteria called the proteobacteria. And there have been numerous studies showing that the proteobacteria, which have high levels of LPS in their cell wall, are associated with greater inflammatory conditions in animals and also humans. This is a study that looked at human preterm babies and also looked at the microbial ecology of the gastrointestinal tract in babies who were given TPN versus babies who were being enterally fed. And again, the microbial ecology differed markedly in these two groups. And there were more of the proteobacteria in the babies who were on TPN versus those babies who were the control babies who were being enterally fed. Another study, which was a retrospective observational study that was done by Cami Martin's group at Harvard, looked at babies who were fed early, this is prior to 4 days, versus late after 4 days. And they looked at some of the adverse outcomes, which included necrotizing enterocolitis, retinopathy of prematurity, chronic lung disease, etc., all of these comorbidities. And they found that the late enteral feeding group had a much greater association with all of these comorbidities. And this is a univariate analysis. They saw the same thing with a multivariate analysis. But again, this was retrospective, observational, not prospective randomized. But another interesting finding was that at 2 weeks, those babies who were fed late had higher levels of pro-inflammatory mediators in their bloodstream, such as IL-8. And this is associated with the development of inflammatory damage, such as lung damage and also central nervous system damage. So late feeding can be associated with a greater inflammatory response. A multi-center study from the UK looked at 2 incremental milk feeding rates in preterm babies to see if giving 18 milliliters per kilo per day versus 30 milliliters per kilo per day increments on a daily basis would be safe and would result in differences in neurodevelopmental outcome. They followed these babies until they were over 2 years of age, and they found no differences in neurodevelopmental outcome. But of interest was that the 2 different incremental feeding rates did not result in greater incidence of necrotizing enterocolitis or other adverse outcomes within the neonatal intensive care unit. So some of the questions that we have, some of the dogmas that we still have are, do we keep feeding babies if they're on indomethacin for adductus, or if they're getting indomethacin for IV prophylaxis, if they're getting blood transfusions, if they're on getting hypothermia for hypoxic ischemic encephalopathy? Well, let's look at this first. This is a study that was done at Baylor University in piglets, looking at superior mesenteric artery blood flow. And while these piglets were being enterally fed, here's the level of superior mesenteric artery blood flow. When they were switched to TPN, the superior mesenteric artery blood flow actually decreased. Now, why do we have a rationale, or what is the rationale for not feeding babies while they are on indomethacin or some of these other vasoactive agents? Well, it's thought that perhaps when we feed these babies, what's going to happen is that you're going to decrease the blood flow even more. Well, this slide, at least in this study of piglets, shows that you may be actually exacerbating the situation if you give indomethacin and you stop feeding the babies, because that will actually even decrease the blood flow more, at least on a theoretical basis. Here's a study that was done by Ron Kleiman and colleagues looking at enteral feeding during indomethacin and ibuprofen treatment for patent ductus arteriosus. And if you just look at the conclusion at the bottom, infants required less time to reach the feeding volume and endpoint if they were given trophic enteral feedings when they received indomethacin or ibuprofen treatments. So this suggested that it was safe and also efficacious to provide feeding to babies who are on indomethacin. What about babies who are receiving hypothermia for hypoxic ischemic encephalopathy? There are many guidelines that say that we should not be feeding these babies, and the usual rationale that I hear is that these babies' gastrointestinal tracts are just not functioning, and if we put any food into their gastrointestinal tract, they are going to develop necrotizing enterocolitis. That was never shown. In fact, very early studies done over a decade ago where they compared the Swedish technique versus the UK technique, where in the Swedish technique, they fed babies, and in the UK technique, they did not feed babies. They found no difference in terms of adverse outcomes. So at the University of Florida, we did a small study where we looked at enteral feeding as an adjunct to hypothermia in neonates with hypoxic ischemic encephalopathy. And here's what we found. We found that minimal enteral nutrition in the babies who received it had a reduced length of hospital stay. The babies who received the enteral nutrition, they were associated with less days receiving parenteral nutrition, and time to full oral feedings was less. Minimal enteral nutrition was associated with a significant reduction in certain pro-inflammatory cytokines. And the brain MRIs were not significantly different between the two groups. And certainly we saw no differences in terms of necrotizing enterocolitis, but this was actually a very small cohort. Now here's a question about this baby. This is a baby who is being fed 2 milliliters of breast milk, and it's 2 o'clock in the morning. And the nurse calls you and says that this baby has 2 cc's of gastric residuals. What do you do? So here's the quiz. So probably you'd want to do the third one, ask about the physical exam and examine the baby yourself. But a more important question is, why do we do gastric residuals in the first place? Gastric residual evaluations there was something that this was a practice started in neonatology that was really not evidence-based. And so a few years ago, we did a prospective randomized trial of doing gastric residuals versus not doing gastric residuals. And this was published in JAMA Pediatrics just a couple of years ago. And the title of this article was Effect of Gastric Residual Evaluation on Enteral Intake in Extremely Preterm Infants. And what we saw here was that evaluating gastric residuals is totally unnecessary. And the practice of doing gastric residuals actually decreases the delivery of enteral nutrition to extremely preterm infants. And we also found that not doing these was totally safe, that we did not see any difference in adverse outcomes by not doing gastric residual evaluations routinely. Now, in 2012, the American Academy of Pediatrics recommended what we should be feeding to our preterm babies. And of course, human milk is what we should be feeding to these babies. And if baby's own mother's milk is not available, we should be providing donor milk. But there are some problems with both baby's own mother's milk and donor milk. Donor milk is pasteurized, and a lot of the good bioactive ingredients in baby's own mother's milk, the fresh baby's own mother's milk, are lost. We lose the lipase, we lose the alkaline phosphatase, we lose several of the immunoglobulins, and also live microbes that may be bioactive in the gastrointestinal tract. We also know that the protein requirement of the fetus is quite high, and that the protein requirement of the extrauterine fetus, or our extremely low birth weight baby, is also high. And if we were just giving donor milk to these babies, they would be receiving about 0.8 to 0.9 grams per kilo per day of protein. So we would need to be giving around 330 milliliters per kilo per day of term donor human milk to meet this requirement. And many of our babies just cannot tolerate this large quantity. So one of the things we need to do is fortify this. And we fortify this with protein. There are many forms of protein available that we can fortify the donor milk with, and also the baby's own mother's milk. Here's an interesting picture. What do you think is going on here? Well, this is the baby's arm, and that's the humerus, and the humerus has a displaced fracture. This occurs all too often in neonatal intensive care, and many of our preterm babies are getting low calcium. They're not getting very much vitamin D. They're getting diuretics, and they're also getting steroids, and all of these predispose to bone fractures in these babies. And we do know from several studies, including this study by Eckhard Ziegler, that we need to fortify calcium and phosphorus in human milk. So here's the human milk calcium and phosphorus levels. Here is what is actually required. So we need to do something to fortify the calcium and phosphorus to help prevent this kind of a catastrophe. Now, growth curves are commonly used in neonatal intensive care, and here again is the growth curve that I showed you before, and we see the lagging behind, and the ideal is to have this happen during the baby's stay in the neonatal intensive care unit. That is very, very difficult, and unfortunately, if we do see falling off of the growth curve, this already means that we are behind the curve, and there are many long-term effects that may have already occurred after falling off the growth curve. And we are now entering a new era of neonatology, and this is the era of artificial intelligence and nutritional multiomics and precision nutrition. And we are just beginning to do some studies that look at various features of preterm babies. So for example, if they were born IUGR, if it's a boy versus a girl, if the mother was exposed to antibiotics during pregnancy, if there was preeclampsia, putting all those features together along with some laboratory features, the microbiome, looking at inflammatory mediators, looking at some of the metabolites in these babies, and putting them together into a systems network analysis and using artificial intelligence, we should be able to, in the future, be able to develop biomarkers that tell us well ahead of time which babies should be getting certain kinds of nutrients that we can personalize for these particular babies. So that's the future. This is going to take some time, but I think the technology is there and or still being developed, but it will be there. So I'd like to stop here with some take-home messages. Early nutrition in preterm babies can be safe and efficacious and may prevent significant morbidity. We should be able to use the gastrointestinal tract. Many of the dogmas that have prevented rapid incorporation of early nutrition have either been disproved, not based on fact, or weak. And enteral nutrition has many benefits for the extremely low birth weight infant. We should use the GI tract wisely whenever possible. And not all preterm infants are the same, and the future will need to focus on a more personalized approach that accounts for specific gestational age and degree of illness, and also omic considerations. And I'd like to stop there and thank you for your attention. I'd be happy to answer any questions.
Wow, thank you, Joe. Amazing talk, challenging almost all our current practice, I think. While people are waiting to either type their questions on the chat pane or to unmask themselves to ask you in person, I know Rahul's got a burning question. So Rahul, first tips to you.
Hi, I had a question. So in addition to the calcium and phosphate that we supplement in our human milk fortifiers, do we need to give more calcium and phosphate as an additional daily requirement?
I think that if we are providing as close as we can to what the daily requirement is, we should be okay.
Okay.
And I think the other thing we need to avoid is if possible, such common use of steroids and diuretics. I think that these are two drugs that are used, probably overused in the neonatal intensive care unit, and also contribute to some of these bone problems that we see in our preterm babies.
Thank you.
Joe, can I ask, how long did it take you to convince the nurses not to do gastric residuals?
So this was, I think we had a very special opportunity here, because one of the people that I was working with, Leslie Parker, was a professor in the College of Nursing, and she had a close relationship with our nurse manager in the neonatal intensive care unit, and also had a very close relationship with the nurse practitioners and also the nurses in the neonatal ICU. And we would talk to them and let them, just give them in-services. And they were very supportive of this study when we started it. Initially, there was some resistance because this is the way that we have always done it. But I think they began to understand how important that this really was, and that the information that we had was really very lacking. And we also were able to get a National Institutes of Health grant to do that prospective randomized study, which was very helpful.
Right. Hey, maybe you can stop sharing. We can see more of you.
Okay.
Okay, now the questions are pouring in. So we'll start from, at Hunan, Ilana says she would like more instructional experience in iron and vitamin D supplementation. Or maybe in that 5 seconds, you could do that. Another talk, Ilana, maybe? Yeah?
Yeah.
A very important question.
Sure. Yeah, I think that usually by 2 to 3 weeks after birth, we should be trying to supplement iron. And the amount of iron we should be giving is around 2 to 4 milligrams per kilo per day. That is the usual recommendation, unless the baby is on erythropoietin, which is then increases the dose to 6 milligrams per kilo per day. Now, the other thing that we have been doing is if the babies get transfusions, and we look very closely at the serum ferritin. If the serum ferritin is high, we do not give iron.
Okay, thank you. Okay, Rohit asks, how do you assess feed intolerance when we shouldn't be doing gastric aspiration? Abdominal girth measurement is not reliable. I guess the question is, what other measures can you use?
Well, I think that the gastric residual measurements are just as unreliable, if not more unreliable, than the abdominal distension. gastric residuals are all over the place. And also, if you do the gastric residuals and if you see that they're just a little bit off color, the nurses will sometimes say, oh, this looks yucky, and they throw it away. And the baby has been working really hard to try to put out acid and some of the stomach enzymes to try to digest that. And you're just throwing it away when you do the gastric residual evaluations. And when the nurses draw back on the catheters, those little holes, you may be doing little biopsies each time that that the nurse draws back to try to do the gastric residual evaluation. So I think that from a teleologic viewpoint, as well as the randomized controlled prospective study evidence, the use of gastric residuals is not worth the effort that we put into it. Okay.
Okay, I might go on a different tack now and ask Justine Parsons from Newcastle. She's a nurse. She's one of our nurse educators in the neonatal unit in John Hunter. Justine, can you unmask yourself? Because you put a comment there saying that it's more trouble convincing the doctors, whereas in our nursery, it's the nurses, I think. So if any nurses online from the Royal as well, you could put in your comment. Justine?
Hi.
Oh, she's too shy. Hello.
Yeah. No,
How
here
are
I am.
you?
Good, thank you. Yep, we didn't have any trouble when we explained to the staff that it was possibly more harmful doing gastric residuals, and so we talked about the harm that was being introduced potentially, and that all of those goodies should remain in the gut and not up and down the tube all the time. Also, then the discussion about bacteria and things that are colonized in the tube and what we're doing by stirring all of that up and reintroducing it to the gut up and down the gastric tube. So yes, that hasn't been difficult, but we've just launched a new enteral feeding guideline here and are having some difficulty. So I noticed Kurt has said the same thing about how long does it take to successfully introduce an early feeding guideline, because we have received a lot of pushback, and yet I'm pleased to have watched your talk, Dr. New, and note that our guideline fits in very nicely with what you have presented today. So that's great.
Great. And by the way, we just recently published a paper on the microbiome of babies who were on the who were randomized to the two different arms of the gastric residual evaluation. And there were no differences in the fecal microbiome of those babies who had the gastric residuals measured versus those who did not. So just if there's any concern about one doing more colonizing than the other, there, at least from the perspective of the fecal microbiome, we saw no differences.
Thank you. So while we're in Newcastle, I might bring Kurt online. Kurt is one of the neonatologists there, and sounds like he might have had problems introducing an early feeding guideline. Kurt, what's your problem?
Julie, hello, Professor Liu. There was indeed a very interesting talk, repeating but also adding towards your earlier talks about how good it is to do early feeding. And we should just, I don't know, we should move with this movement. I think that's really important. No, I don't think I have much to add to what Justine was bringing. We got a lot of feedback, and we are just reaching out and seeking, like, how can we get our colleagues accepting and get online. I already send them, like, now look at this talk, because Professor No did a talk, I think a couple of months back, for the Indian Society, and I said, no, look at this talk, it's really important to hear the experts talking about this topic. But yeah, now Justine summarized it all. Thanks.
So you're not regularly starting early feeds yet?
Well, I am, but that gives confusions on the floor. Okay. And that is also what you don't want. You don't want confusion on the floor with your nursing staff. You want them to do a, just a guideline which works.
Standardized, yes, that's right. Okay, thank you guys. So quick question here from Dr. Uncle. Do you feed with a UAC and a UVC? That's a massive conundrum for many of us.
Absolutely. That is absolutely, there's no contraindication to putting food in the gut with a UAC or UVC. No information, no data that suggests that this is going to increase gut injury if you have a UAC or UVC in it if you feed the baby.
Okay, all right. We were very cautious still, I think, most of us. Yeah. Okay, and Dr. Hari Ram, your friend from Bangalore, has
Yes. Hi there.
hello, Dr. Hari Ram. Would you like to unmask yourself? Dr. Hari Ram, is he still there? Well, he's asked about glycerin enemas. I think we had a talk a couple of weeks ago from the Japanese, and they showed us like real life action videos of nurses doing glycerin enemas on the babies, and everyone was like, "Oh my God!" What's your comment?
Well, the comment on that is I don't think that they should be done routinely. And the evidence for routine administration, there's a meta-analysis looking at this. The data is very poor in terms of showing any kind of real benefit of doing routine glycerin suppositories or glycerin enemas in our preterm babies. I think that if you don't put anything into the gastrointestinal tract, nothing is going to come out. And so I think that one of the best stimuli for making a baby poop is to put some food into the gastrointestinal tract. That stimulates the motility, it stimulates whatever primitive gastrocolic reflex might be there. So I think that that's the most important factor to do these procedures. I think is superfluous, and there may be certain babies where it may be helpful, but to do them routinely, we don't have the evidence that shows benefit.
Dr. Hari Ram, I can see you. You can unmute yourself. You're muted. He's waving from his car, but he's muted. We can't hear you at all. Oh, there he is. I think you're still muted, Dr. Hari Ram. He's technologically challenged. Do you want to say something, Dr. Hari Ram? I think you're still muted. No, he's gone. All right, okay. We might quickly move on then. Oh,
yeah, I see him.
I see him too. Yeah. So hello.
Okay.
Anyway, we'll see you in Bangalore. So maybe have you got time to run through a couple more comments, Joe?
Sure.
Yeah.
Sure.
So Dr. Arjun asks, well, your opinion about the role of domperidone and erythromycin for feed intolerance.
Yeah. So domperidone, I have never used domperidone. It is supposed to stimulate motility of the gastrointestinal tract, but similar to, it has a slightly different mechanism compared to cisapride or propulsid, which is a drug that we used prior to about 10 years ago. And it was being very commonly used here in the US, but then it was taken off the market because it caused cardiac dysrhythmias, torsade de pointe cardiac dysrhythmias. And that's one of the problems with domperidone also, that it can cause prolonged QT. So I don't use domperidone. I have used erythromycin, and I am guided by some of the work that was done by my colleagues, P.C. Ung and colleagues in Hong Kong, where they have written several papers on the use of erythromycin in preterm babies for feeding intolerance. And the way I generally use erythromycin is on the high dose. I use it enterally, give it for 2 to 3 days. And if I don't see a benefit, in terms of feeding tolerance, I stop it. If I do see a benefit, I will stop it in about 2 weeks, because then the baby has probably grown out of the need for erythromycin. Most of the feeding intolerance that we see in our babies is developmentally related, and the babies will outgrow that and outgrow the need for the erythromycin. I have never seen pyloric stenosis develop with erythromycin treatment, but that is a concern that some people have had with the use of erythromycin.
Definitely.
But I only use it very seldom. I would try other techniques such as prolonging the feeding infusion to an hour or 2 hours, rather than going straight to the erythromycin.
Right, and you will continue with feedings, I suppose, as long as there's some food going in.
Yes.
Yeah.
Yes.
Mhm. All right, may I take one last question from Dr. Harian from Brisbane? Elizabeth, I can see you online.
Yep. Hello. So yeah, we've started. Can you hear me?
I can.
Very well,
Yeah.
thank you. Yeah.
So we've stopped doing gastric aspirates some time ago, and we also before that introduced a package of very early feeding and very what some people might call aggressive TPN, including starting lipids at 2 grams per kilo per day on the first day. But the question I have is whether we should commence donor milk on day 1. What we prefer to do is wait for mum's milk, because we worry about the message we're giving if we reach for the donor milk straight away. So we try and really push on encouraging mum to keep expressing and reassuring her that her milk will come in. We don't have any good evidence that it does put mums off, but that's what we worry about. So I wondered what you're feeling about rushing in with donor on day 1 versus being patient for mum's rich colostrum was.
Yeah. So our experience in our institution, we actually, Dr. Parker, my colleague from the College of Nursing, wrote a paper on this and showed that when the American Academy of Pediatrics guidelines were instituted in our center, one of the things that happened was that our use of baby's own mother's milk dropped. And what happened, I think, was that the nursing staff, the mothers, people did become complacent. So you're absolutely right, that can happen. But there are centers where they really made sure that the mothers and the nursing staff were very cognizant of the fact that the donor milk was only a very temporary bridge, and as soon as possible, the baby's own mother's milk should be used as soon as possible. So I think that part of it is the attitude and the complacency of the individual center.
Thank you.
One question.
Oh, yes, of course. Who's?
Many,
Harry.
Sorry. Yeah, of course, Dr. Hariram. Nice to meet you.
Okay. See, many extremely low birth weight neonates pass meconium on day 5 or day 7 sometimes. Have you noticed any link between this and feed intolerance or feed tolerance?
I think in certain babies that there may be a relationship, but it's to put that into any kind of a strong association. I don't think that we can do that from a statistical standpoint, but I think that there are some individual babies that I'm convinced that some of those babies do have like a meconium plug or something that makes them have more difficulty with enteral feeding. So I've become maybe a little bit less dogmatic about allowing some irrigations or doing gentle rectal swabs, or doing something to try to pass that baby, for that baby to try to pass meconium.
I have another question.
Yeah.
Hello, can you hear me?
Oh, yes, of
Yes.
course.
Have you noticed any change in the feed tolerance or feed intolerance when you compare human milk fortifier versus bovine milk based human milk fortifier? We have been using human milk fortifier in our unit, and we have found good feed tolerance in extremely low birth weight babies. What are your comments?
Yeah, I think that the head-to-head study on that is in the process of being done. And so I can't tell you what the results of that study is, but I think that probably within the next year we'll have those results.
Thanks, Joe.
Thank you, Harry.
Thank you, Dr. Hariram. Okay, I think it's Dr. New's bedtime now. Joe, that was amazing. Thank you. You've challenged a lot of our current practices, and it's food, haha, joke, food for thought. If you're okay with the recording being posted, I think a lot of people are waiting for it. It'll be appreciated. So for those in the audience, any other questions, either email me or Dr. New directly, I guess. He will answer your questions. Is that right, Joe?
Yes.
Yes.
I will try.
Thank you so much. Yes. So I can't see you anymore. What happened to you? Hang on a minute. View speaker. Okay. Dr. Hariram is still there. Dr. Hariram. Anyway, thank you everyone for joining. I'll post the recording for the talk in the next few days. And again, thank you to Joe, and have a great night, everyone.
Thanks,
Thank
Joe.
you.
Thanks.
Thank you, Joe. Good sleep.
Bye.
Thank you.
Good night,
Bye.
everybody.
Bye-bye.
Good afternoon. Bye-bye.